Thanks, Doctor. Up next, we have Melinda. Hi, Melinda.
Hello, can you hear me?
Yes.
Okay. I have a question. In my last physical, I was diagnosed with an LBB, a left branch bundle block, or if that's what it's.
Left bundle branch block. Yes.
Yes. What is that?
A left bundle branch block. So basically, just to give you an overview, the heart has its own electrical conduction system that has these normal pathways. And you have your God-given pacemakers, we call it the sinus node. It's an electrical initiating tissue that lives in the upper part of the right chamber near the superior vena cava. And the brain sends signals to the heart saying they need to be faster, slower. And the inputs, the central neurological inputs goes into what's called the sinus node. It controls the rate and rhythm. So electrical activity starts from the sinus node. It goes to the upper chambers called the atria. The atria have their own little wires or electrical pathways. Electrical signal travels through that. Then to connect to the lower chambers, it goes to what's called the atrioventricular conduction tissue. We call it the AV node. And the AV node serves as conduction tissue and a filter. So conduction, when it gets to that conduction tissue between the upper and lower chambers, it slows things down. So it makes sure that conduction doesn't go too rapid, because you can develop atrial fibrillation. And what keeps atrial fibrillation, which is a rapid radical atrial beat, from causing ventricular fibrillation and death, is that AV node. It filters those upper chamber beats. So then the conduction goes from the AV node to the His bundle, which is another special conduction tissue, and then it goes through the bundles. There's a left bundle and the right bundle. These are just the main conduction pathways that send electrical signal to the left side and the right side of the lower chambers at the same time. So what happens is that you have a sinus beat that starts, electrical signal goes to the upper chamber, then it goes to the AV node, then it goes to the lower conduction panels, and then the upper chambers beat the same time when they get the electrical signal, and the lower chambers beat the same time when they get the electrical signal. And the pathways allow electrical signal to pass through effectively and efficiently through both chambers. Now, some people have what's called a bundle branch block. So the left bundle may be blocked or the right bundle may be blocked. In the case you're talking about, the left bundle is blocked. So when the electrical conduction gets through the upper chambers, goes to the AV node, when it gets to the left bundle, it doesn't conduct. So all electrical conduction to the lower chambers, the ventricle, goes to the right bundle. So that the right chamber conducts first, and the electrical activity slowly goes to the left ventricle through back doors, back channels. It's almost like the main highways close down, so they have to take a detour and go around one segment and take the back streets. But the left ventricle conducts second. So you get with left bundle branch block, you have conduction on the right before the left. So in most people, it doesn't cause a problem. I've seen lots of people with bundle branch block and they live normal lives. And there are many reasons that it's there. It could be a true structural abnormality. It could be just a physiological abnormality. I've seen some individuals, when the heart rate gets to a certain rate, they can have a rate-induced bundle branch block where the conduction goes down one bundle faster than the other. So there are many causes to this, but in essence, it's an electrical abnormality. It's seen on the EKG, and we can say, based on this EKG pattern, you have a left bundle branch block. The underlying etiology may not be obvious based on the EKG, but those are the findings, and that's what it's describing.
Thanks, Doctor. Up next, we have Stephen. Stephen, if you're looking forward to your question.
Just a really great presentation, Doctor. I appreciate it.
Thank you.
I'm 66. I've had a stress test. It was clean. My numbers in terms of cholesterol about what you were showing on, after, I'm whole foods plant-based. So, I'm not 150 total, but I'm like 180 and, it's like that. So I'm just wondering, how do you think about it? A low dose statin would get it down lower. Does that help me, or just don't worry about it?
Yeah, my personal thinking in general is that I don't recommend drugs if I can do something different, to bring the normal down. Because one, I don't treat numbers, I treat patients in general. So if I have somebody with a cholesterol of 150 or 170 or okay, the number is what the number is. I don't treat to get a number below a certain number. I mean, I understand, 150 below 150, ideally, it protects you from heart attack, but that's really a statistical phenomenon more than anything else. And so when I'm in front of an individual patient, I look at the broad scope of things. So let's say someone's eating a whole food plant-based diet, and maybe they, say, okay, I eat, I microwave my food or do whatever. And maybe we can make a simple change there. I mean, sometimes there's some simple change you make that really won't, cause much grief in your life, that you say, oh, I can do that easily. And then, you may have a 50-point drop in the number. But typically what I do is if someone's healthy, they're doing well and so on, we just tweak things. But I typically don't just throw a statin at them, because, I mean, what's the purpose of the statin? I mean, the thing is that, is it to get you to 180 to 150? If that's the purpose, can we do that by some other means? Because, statin drugs or pharmaceutical drugs have adverse effects, and they're not natural substances for human consumption. So I use them very sparingly. I use them a lot, but, relatively speaking, I use them very sparingly. Not just statin drugs, but medications in general, only for the purpose of getting some acute short-term benefit and helping the patient get to a lifestyle change so that they don't need these drugs. So your situation, or the situation you're describing, I don't know what a statin does in that situation. And so I'd have to kind of, if I was managing a patient, like yourself, like you described, I would step back and say, okay, what are all the components here? And, it's not just this number of 180, it's the whole picture.
Thanks, Dr. Montgomery. Up next, we have Sangeeta, if you'd go ahead with your question. Thank you.
Thank you, Doc. It's a wonderful, wonderful presentation, and I absolutely admired your approach: food, then superfoods, and then followed to the pharmaceutical treatment. I have some young patients, Doc, which are like in 35 or 45, and they have like a very strong history of heart failure. And this particular patient, and I would say general few patients, are running like a mixed hyperlipidemia, and cholesterol is certainly not very high, like it's 230s and LDL in 140s. So certainly PCP referred to cardiologist, and cardiologist, she came to me as a nutrition consultant. We started like a perfect food-based and lifestyle factor. She's doing physical activity to the eating correct, anti-inflammatory. And recently cardiologist started her on statins, actually, and the Bistolic. And our concern is that certainly needed in this case, or the things can be managed in her case? What is her risk, or she needs to be on statins? What would be your approach here?
Yeah, good question. I've treated a number of patients with familial hyperlipidemia. The LDL numbers are typically higher than what you described. The cholesterol numbers are typically higher than what you described. It's a big picture that I look at, and it doesn't mean I do use statins or don't use statins, but my general approach with patients with strong families, so there's a strong identified genetic component, I'll put it that way. I go very aggressive on the lifestyle side. So, I'll put them on, raw detoxes for prolonged periods of time. We may or may not use supplements early on, and we see the early changes occur. I recall one patient we started treating years ago, and she had a total cholesterol of 400 at the age of 16, and she's like pencil thin, and so, and we were seeing her at the age of 30 or whatever the case is, and so we detoxed her, and she elected not to go on statins. And there were some other reasons I don't remember offhand why, and I think there were legitimate reasons. But we got her total cholesterol. It was like started 400. We got it down to, I think, the low twos, and maybe we dipped below 200 with her total cholesterol. So she may not have gone to the ideal 150, but she went down to the low 200s, and 150s. And she had some other health issues that had really corrected. The point is that when you go on a total aggressive lifestyle change, keep in mind that a cholesterol measurement is a number, and that's one thing. So let me use this analogy to make the point. Let's say, for instance, you have a very significant injury at a young age, and you have a very big scar, and you know, you're bleeding out, and at a young age, you aggressively go and get it sutured, all of that. And over time, you have a scar, and that tissue is healing. So you go 20 years into the future, you still have a scar because of that injury. But your arm works fine, and you're not having pain, and everything's functional, but you still have a scar. These abnormal lab values, and I like to think of it in some ways as a scar, if you will. And the reason I say that is that in somebody with familial hyperlipidemia, it's not only genetics, they also suffered an environmental insult, because everybody I've seen with familial disease also had familial lifestyle changes, which they ate the standard American diet and so on. And so that acute injury they had early on is manifesting as a severely abnormal lipid level. And granted, we will do a lot of things on a lifestyle basis to correct that, but their lipid levels may still remain abnormal, which means hepatic metabolism haven't completely normalized. But I don't know if that means that we need to put pharmacological agents in there to totally normalize that number. I look at the whole patient, and when I'm making that clinical judgment with that patient, that lipid number may be abnormal, but there's no evidence of coronary stenosis, or no evidence of unstable plaque. Cardiac function is normal. There's no evidence of ischemia. Or if there's ischemia, we correct the ischemia with lifestyle. So if we correct all these other components, and the lipid number may not be ideal, I may not use a statin to correct that. I have another patient with high cholesterol, but she's aggressively applying lifestyle. We're manipulating lifestyle. She doesn't have symptoms, highly functional. So I'd like to treat the whole patient. And that's especially true with these patients with these heavy genetic predispositions, because the simple thing to do is to throw a medication at it. I don't say that I absolutely don't use a medication, but the patient able to use aggressive lifestyle interventions optimally, then I think you're going to do better in that route than adding a medication. Because adding a medication by lowering cholesterol, yeah, that's a good thing, but there's also adverse effects of that medication, and you have to be cognizant of that. And I am when I think about whether to add a medication or not.